I want to talk this morning about BPH and lower urinary tract symptoms, specifically about surgical treatment of BPH. So particularly because with respect to the AUA BPH guidelines panel, I sit on the panel. I do not, it's very important for me to say this morning, I do not represent the entire panel this morning. I represent myself talking about the different aspects of the new guidelines. How many folks in the room, show of hands, use the AUA guidelines rather on a regular basis? So most folks, and I think it's especially important for a couple of different reasons, not the least of which is that the AUA is now partnering with the ABU and cross-talking with the ABU in a way that's never happened before. So you're going to see a lot more crossover, if you haven't in the past, between the specific material that's in the AUA guidelines and the specific material that is appearing in the ABU maintenance of certification exams. I don't know where everybody is right now with respect to that, but you can always fall back on the AUA guidelines. And the AUA guidelines with respect to BPH, they were released in May in 2018 at the meeting in San Francisco. It had replaced a prior update that had last come out in 2010, and then a validity review had been done in 2014, which simply meant that a couple of us got together, looked over the evidence, and said, nah, not a lot of big changes. We're going to keep them essentially the same way that they are now. These are all new guidelines. Completely new, replacing the old set of guidelines. What I want to emphasize this morning is, in fact, what's new with respect to the guidelines. And you can find the guidelines in the Journal of Urology. So if you're still getting your printed copy of the Journal of Urology that comes in the mail, there is an article from June that will be in that. It's also available online. I think most of us prefer to use the online version. And the BPH surgery guidelines, like every other guideline that's out there, is in the same exact format. So all of these guidelines, whether it's castrate-resistant prostate cancer, whether it's non-muscle invasive bladder cancer, whether it's this, every single guideline is in the same exact format. Every single guideline tries to keep to the same language to make it easier for you. These are your AUA tax dollars at work. The AUA puts a lot of resources, a lot of time, and a lot of effort into doing these. And so each of the statements, the guidelines, is broken up rather into specific statements. With respect to BPH, they are just specific statements as opposed to, you'll see in some of the other guidelines, they're index patients. No index patients here, just specific statements. And when you go to the statements, you can click on the box right here, which will say discussion, if you're interested in getting a slightly more detailed outlook on any particular topic along with the references. So the objectives today, we're going to talk first about what's not in the guidelines. Secondly, the guidelines are split up into three broad categories: pre-op evaluation, surgery, and medically complicated patients. And I'm going to touch on each of those three. And first off, what's not in the guidelines? Well, that's easy. The first thing that you're going to notice is what's not in the guidelines, these guidelines, is medical therapy. They're going to be due out within the next 18 to 24 months or so, and there's a very reasonable explanation for this. The explanation is that we were overwhelmed. So when we first approached this topic of BPH, I think we rather naively thought we could do surgery and medication all together. It turns out you can't. And so during the process, we discovered that we needed to focus on one topic. We thought the more relevant topic was surgery because, frankly, more had happened in surgery over the last 8 years than had happened in medications. What's also not in the guidelines, which I think is relevant to our discussions here, show of hands, how many folks in the audience routinely put their patients on 5 ARIs prior to, say, a TURP if they're not already on one? Yeah, I do it routinely. If you go back and you look at the 2010 guidelines, there's insufficient evidence to support its use. That is the specific statement. So not for, not against, but you can't support it. But since then, there's been some really good data, really good specific center data, but I think more importantly, claims-based data. So like big data sets, looking at Medicare, looking at transfusion rates. And it's pretty robust. Whether you're doing a laser, whether you're doing a TURP, if you have patients on a 5 ARI for, say, 4 to 6 weeks after their surgery, if you continue it for that long, you will decrease the incidence of bleeding, whether it's that initial bleeding that you see within a couple of days of doing the surgery, surgery or that bleeding, that frantic call we get 4 to 6 weeks later with someone who is crystal clear, doing fine, and suddenly they're saying that they've got gross hematuria. I typically will leave my patients or start my patients who aren't on it, leave them on a 5-ARI for just 30 days, and that's worked out fine. So first off, preoperative testing, and I'm going to go through the guidelines in order, starting with statement 1, because that's how the guidelines are organized. Preoperative testing, surgery, and then medically complex patients. So first off, statement 1 says you have to do essentially 3 things if you're going to be taking somebody to the OR or considering taking somebody to the OR: a medical history, a UA, and a symptom evaluation. That's pretty straightforward, pretty specific. A lot of folks will come back and they'll say, what about a creatinine? Shouldn't every single patient get a creatinine? It's very reflexive for us. Well, the 2010-2014 guidelines said no, that every patient walking through the door with lower urinary tract symptoms attributable to BPH does not need a creatinine. And we so far hold to that. We don't specifically require a creatinine on every patient, but you're certainly welcome to get one if you think it's clinically indicated. Symptom evaluation, pretty routine. I think most folks in the room will get either an IPSS, International Prostate Symptom Score, or the AUA equivalent, the AUA Symptom Index. What we do to enhance our clinic flow is these patients will get the forms typically in the waiting room, and then our MAs are already entering the data into our electronic health records, so I just have to use what's called a dot phrase, and it pulls it right up for me right away as I'm sitting down in the room with the patient. We're also piloting a program, if anybody really is into EHR and IT, we're piloting a program. We're going to start having patients fill them out at home before they come in, the patients who are interested. That is, again, just to facilitate the flow, to make people happy. Not to go too far off on patient satisfaction, patient experience scores, but I think you're all probably aware that the number one things that folks will complain about, other than parking, which is a complaint we get all the time, is wait time. So anything that we can do to make it more convenient for them, our pilot data have shown that if they check in online, they want online this, they want online that, they want efficiency, anything we can do to help that, then it enhances our flow and their experience. So statement 2, prior to surgical intervention, clinicians should consider assessment of prostate size and shape. This is new. This was not in the old guidelines, and this was a specific topic of discussion. And what we are recommending is that you get an ultrasound. It can be transrectal, it can be abdominal. You can do cystoscopy, you can do both if you like. And then we also recommend you don't have to get an MRI specifically or a CT specifically, but if they've had prior axial imaging, you can use that for a volume estimation. And the reason why we added this is that we felt strongly that this is something that helps guide the surgical choice, as we'll get to a little bit later, and helps categorize people into particular indications for particular surgeries. This actually should stay, the statements are a little bit off. This is also new. Prior to surgical intervention, clinicians should perform a post-void residual. This is a little bit of a debate. Some of us didn't like that wording, should, but it's in the guidelines now. Most of you are probably already doing this, so I don't think it's really an issue. Prior to surgical intervention, clinicians should consider getting a flow rate. I should say, how many people in the room don't get a flow rate on their patients? Show of hands. Really? So, do not get a flow rate. Really? Okay. Fair enough. That's okay. You just consider it. You've considered it. I'm not going to do it. I'm going to move forward. That's fine. That's why it should say should consider. Yeah, I think that's perfectly reasonable. And I got to tell you, I don't routinely do it either. And so it's interesting to me. This is an interesting audience because other audiences will tell me, what do you mean you don't get a flow rate? So I completely agree, sir. I think it's just your clinical judgment. Absolutely. Yes?
It varies so much based on patient anxiety and
Sure.
fluid they have in their bladder at the time of day. And basically, I think a lot of times it's not because we no longer get paid for PVR, but we get paid for a flow rate.
That's a good point. Absolutely. So we've got several different factors coming into play there. Well, the bottom line is you can consider it, but you don't need to do it. The same standards apply that we're all familiar with. If you do get one, less than 10 cc's per second is considered substantial obstruction. And that's the kind of thing, by the way, that'll pop up on, say, a maintenance or certification exam. You should consider pressure flow studies if diagnostic uncertainty exists. So if you've got that patient with Parkinson's, if you've got the patient with the small capacity bladder and a predominance of urgency or of storage symptoms, well, that might be someone that you might want to consider doing it. But again, the operative words here for the guidelines, nothing is mandated, should consider, and if diagnostic uncertainty exists. Well, what about the surgery? What about the statements related to it? And I'm going to be a little bit broad here because I know we have some other talks this morning specifically focusing on some of the modalities that I will just mention briefly. I think it's good to think about BPH surgery in terms of just broad categories. If you start on this side of the arrow, the base of the arrow, and you move this way with respect to invasiveness, you're going to have the minimally invasive office-based therapies at the base of the arrow, and you're going to have the maximally invasive therapies at the tip of the arrow. Well, how does that correspond to the patient's experience? Well, if you think about it, at the base of the arrow, the office-based therapies, they're easy to use. There's minimal morbidity, and there's typically, as we'll see, minimal ejaculatory problems. Then as you go up to the tip of the arrow, the maximally invasive therapies, well, you're going to have more definitive efficacy, frankly. You're going to have durability of results over years, 10, 15 years for a TURP easily in 80 to 90% of patients, and you're going to have some increased morbidity. Not a lot of morbidity compared to a lot of the other things we do to folks, but increased morbidity with respect to the office-based procedures. And I think that that's a good way to approach surgery in general and to categorize it in our minds as we consider the pros and the cons. Statement 6 relates to indications for BPH surgery. We had never formalized that before. It had been buried in the text of the prior version. Refractory urinary retention, recurrent urinary infections. Notice our use of these terms refractory, again, to give some wiggle room to correspond to clinical judgment. So refractory gross hematuria, recurrent bladder stones, renal insufficiency secondary to BPH, refractory to and/or willing to use other types of therapy. We have a specific statement this year on bladder diverticulum. It's not specifically an indication. So bladder diverticulum, if it is asymptomatic, is not a specific indication for doing BPH surgery, unless the patients have some of the other indications related to BPH surgery: urinary infections, progressive bladder dysfunction, recurrent bladder stones, progressive renal insufficiency. And a point that we make that we think is important: address the underlying bladder outlet obstruction, the BPH, before you consider doing a diverticulectomy. I have seen this happen. In one particular case, I did see someone who had a diverticulectomy, but the underlying BPH was not addressed, and that patient ended up blowing out the diverticulectomy site. So it's very, very important to address that first. Statements 8 and 9 correspond to TURP. It's pretty much the same as it's always been. TURP should be offered. It should be considered. Bipolar or monopolar is just fine. We're not making any judgments about bipolar by any means. Of course, you have to consider elements related to monopolar, the hyponatremia, TOR syndrome. By the way, we don't teach our residents TOR syndrome anymore. It doesn't tend to appear on their exams, believe it or not. Because we all use bipolar for our TURPs, we just don't see it anymore. And it is still considered the gold standard. I'm not really sure I like that terminology personally, but it does appear in the documentation. Statement 10, this is a new one. Clinicians should consider open laparoscopic or robotic-assisted prostatectomy depending on expertise for patients with large prostates. This is new. And depending on expertise, you're going to see that throughout the guidelines because there's many different ways to skin a cat. Folks feel comfortable. They've been trained differently. So we acknowledge that throughout the guidelines. There is no right way to do these. With respect to this one, though, this is new because previous iterations had talked about laparoscopic and robotic as being experimental. And now it's considered to be something that you can consider on a routine basis. Does anyone, show of hands, doing robotic-assisted simple prostatectomies? So a few. Okay. I'm not going to go into a lot of detail because I want to stay on time, and I could give an entire lecture just on this topic. I think suffice to say that the efficacy is comparable to open, and this is all obviously in selected patients. Okay, the one I did this week had a 250 cc gland and refractory urinary retention, and less transfusions, 0 to 3% in most series. Compared to open simple. Statements 11 through 13, no changes, all viable options. Transurethral incision, fine. Small glands specifically in the guidelines. Transurethral vaporization, absolutely, no problems. Green light PVP, absolutely, no problems. All these should be considered. Prostatic urethral lift, this is a new one. This was not previously discussed. I know there's going to be a whole lecture on this topic. I'm just going to stick to what's in the guidelines. Consider for prostate volume less than 80 cc's and a verified absence of an obstructive middle lobe. Why do we have that middle lobe? Because I know our speaker, I'm sure, is probably going to address this. The middle lobe simply because this is what the original FDA indication said, because that's what the studies did. The studies excluded patients with, quote, an obstructive median lobe, the original studies. And so we couldn't comment beyond the original studies because that's the evidence. We couldn't go beyond that. That was the current evidence when we did our review. And then we also recommend that you have to note to patients that symptom reduction and maximum flow rate improvement is going to be less than TERP. You know, that data are out there. The randomized clinical trial has about 5 years of follow-up right now. Applicability to larger glands is unknown. There's one trial of urethral lift versus TERP. Quality of life improvements are similar. And again, this is independent of any FDA expanded indications, which I'll let our speaker go into a little bit later. I'm sure he's going to discuss that. This is also a new point. We draw this point out specifically. If you have patients that are particularly worried about ejaculatory function, then this is a good modality to offer them. Because really, in the studies, there is no de novo erectile or ejaculatory dysfunction. We all have those patients where their erectile function is just fine, but they've got retrograde ejaculation post-op, saved from a TERP, and they're miserable. They will tell you it's different, right? Well, these are the kinds of patients that might be motivated to start with a prostatic urethral lift. Microwave therapy, is anyone in the room, show of hands, still doing microwave? Okay, it's still here. We made a specific statement regarding it. You can offer it. You probably should inform your patients that the retreatment rates are higher than they are with TERP, 10% versus 2% in the studies that are out there. Okay, water thermal therapy. Anyone doing Resume? Show of hands. So a few of you have started to adopt Resume. Same as with the prostatic urethral lift, really. So it's really the same kind of statements we make for Resume. It can be offered for smaller glands, less than 80 cc's. Efficacy is, evidence of efficacy is a little bit more limited. The follow-up is not as long. It hasn't been around as much, and I'm sure our speaker will discuss this a little bit more. So these are what the guidelines say specifically. The longer-term retreatment rates, for example, have not been yet addressed. There's one RCT, one randomized trial that's out there. This is thermotherapy versus sham. The urethral lift data are the same. It's versus a sham modality. Applicability to large glands is unknown. They did not exclude patients with a median lobe, which is why we specifically do not have that median lobe statement within the guidelines. And again, about 2 years of follow-up. And this one also, you can offer it to patients who are really concerned about erectile and ejaculatory function. We pull that out into a separate statement. Statement 19, tuna. Is anyone in the room still doing tuna? Okay, there you go. We did the same thing at the AUA course in San Francisco. Nobody in the room was doing tuna anymore. We don't recommend it. 2010, there were really no high-quality studies noted. Between 2007 to 2017, there were no peer-reviewed publications. I'm not saying like there weren't any good peer-reviewed publications. There were no peer-reviewed publications at all, and the panel felt that it has absolutely no clinical relevance. This is a new statement. HOLEP and THULEP, clinicians, it's the same thing with the PVP, it's the same thing with the TERP. Clinicians should consider holmium, or if you prefer thulium, laser enucleation, dependent on expertise. This is a very specific skill set, as I think we're all aware. It's prostate size independent. Our HOLEP experts on the panel wanted to make that clear. It tends to be associated with larger glands, which certainly you can do it in a larger gland, 120, 150, 200 cc gland, but our panel experts specifically noted that you are able to do it in smaller glands. Most, I think, would argue that if you're selecting patients for HOLEP, it's probably going to be the large glands. Prostate artery embolization. Now, this is a thorny one. We do not recommend it in the guidelines outside the setting of a clinical trial. And I can tell you we're already getting the angry letters to the Journal of Urology from our interventional radiology colleagues about this. The bottom line is, if you have a man who has lower urinary tract symptoms or even is in urinary retention, the quality of the evidence is low. It's just not out there. Most of these series are 30 patients. We did embolization, and then all 30 did great. So it's like a post-pre analysis, and there's all kinds of problems with placebo effect when you do BPH studies. The lift study for the urethral lift is a perfect example. There was what, a 5 or 6 point improvement in AUA symptom score for the sham group. You know, the sham group for the lift study, for urethral lift, was literally putting a cystoscope into the urethra of an awake patient and making a clicking sound, and then pulling the cystoscope out. Most of those men got better for up to 12 months. So there's a significant sham effect. And then there's all sorts of safety data that we're concerned about that just aren't there. Medically complicated patients, this one also is new. Forget the statement, I apologize, forget the heading there. I'll fix that for the final materials for the meeting. Basically, this statement corresponds to the fact that if you have an anticoagulated patient or a patient who's otherwise at a bleeding risk, we recommend the laser modalities, HOLEP, PVP, THULEP, whatever you feel comfortable with, because there are really good data to show that these patients will do better in general from a standpoint of transfusion risk, if you compare them, say, to bipolar TERP. And this is a new statement. So one of the take-home points I would say, and I think something that's emphasized in the language of the guidelines, because we work very hard in the guidelines language, consider the patient's individual situation and preferences, your personal experience and expertise. That's absolutely fine. That's why we build in so many different kinds of ways of approaching it in a valid way. Like I said, as you know, there's many different ways to skin a cat. And then the indications for surgery, the strong indications for surgery.